Chapter 15, Part 2. We let off with glucose tolerance test and lactose tolerance test. We're going to go to arterial blood gases next. Arterial blood gases provide useful information about the respiratory status and the acid-base balance of patients with pulmonary lung disease or disorders. So this would be the rationale as to why they'd be looking at it. The other thing to note too in your textbook is that it provides information about the respiratory status and acid-base balance of patients with lung disorders or diseases. So it's really essential to determine to determine if there's a good flow of collateral circulation. Arteries of selection. The brachial artery, which is in the cubital fossa of the arm, which could be seen here. The radial artery, which is here, and then extends down. And then there's the femoral artery that's found in the leg, located in the groin hair of the leg lateral to the femur bone. This lacks collateral circulation. It's used for patients with cardiovascular disorders, and it's the last choice because it is further away from the heart. Procedure. Determine the patient has been in a stable state for at least the previous 30 minutes. Attempt to calm the patient before collecting the specimen if the patient appears anxious. Before proceeding, determine if the patient is on any anticoagulant therapy or allergic to iodine or lidocaine, because those items will be used to collect. And then we're going to record the patient's temperature, oxygen concentration, and respiratory rate. Because if the patient's really anxious, the respiratory rate might be elevated. We might have to wait to do the procedure. A patient's temperature is really important because if the patient has a fever, this could also modify the test results. So site selection. You're going to wash your hands, put on gloves and a facial mask and protective laboratory coat, and palpate the radial artery in the forearm. The radial artery in the patient's non-dominant hand is usually the best choice. With the forefinger or the first two fingers, you're going to press at the site to find the artery. Never use the thumb for palpating because there's a pulse in the thumb that may be confused with the patient's pulse, and avoid any site that has a hematoma that was previously used for arterial puncture. So we'll do pressure like this on the ulnar and radial arteries. So the procedure to determine which hand we would use is called the modified Allen test. It's to check for adequate collateral circulation using the modified Allen test. It's to perform before using the radial artery for blood collection for ABG analysis. It makes certain that the ulnar and radial arteries are providing collateral circulation. So the procedure is described in detail in your book, but we're going to compress both arteries with your index and middle fingers and ask the patient to tightly clench his or her fist. Ask the patient to open his or her hand and release the pressure as shown here. We would not use the thumb as shown in this picture. Release the pressure on the ulnar artery. The Allen test is positive when the hand fills with blood within 5 to 10 seconds. If the color does not return to the hand after 5 to 10 seconds, the Allen test is negative. A negative Allen test indicates the inability of the ulnar artery to supply blood to the hand adequately and shows a lack of collateral circulation. Therefore, the radial artery should not be used in a negative Allen test. So see here, we should see the hand go back to its normal color, and part of the hand is not. So this would be a negative test result. Okay. Also shown here, it should change to white and then turn back to its normal pale color. This would be an example of a positive test. And we can then use that artery for ABGs. Generally, respiratory collects these. Some hospitals train phlebotomists to do these, but you do need to be trained to perform the procedure. You clean the area well with a chlorhexidine swab. Use a pre-filled heparinized safety syringe with a needle to withdraw the sample. You're going to pull the skin taut and pierce the pulsating artery at a high degree, usually 30 to 45 degrees against the bloodstream. When approximately 1 ml of blood is collected, withdraw the needle carefully to avoid introducing bubbles into the syringe. Immediately transport to laboratory for testing and hand deliver within 15 minutes. Before leaving the patient, leave a pressure bandage on the puncture site. It's really important this is collected in a syringe, so a syringe of blood will go to lab. Procedure 15/6 in your textbook goes over the procedure in detail. Please review so you're familiar with the procedure and how to handle this sample. The other thing I want to make note of, it does go into a closer look on page 492 of the modified Allen test. Just be aware for future testing what a positive and negative test result looks like and what does it mean for patient testing. Okay, we're going to continue on in our lecture here and go to therapeutic drug monitoring, or what we call TDM. It's used to monitor the serum concentration of certain drugs. So when are we doing this? If the drug level is highly toxic, when underdosing or overdosing can have serious consequences. If the use of multiple drugs may alter the drug action. If individual patients metabolize drugs at different rates. If the effectiveness of the drug is questionable, and if the compliance with medication regimen is a concern. This is a list of reasons why we would draw these patients on a regular basis to determine the therapeutic window for that test. So a trough level is the lowest concentration of the drug in the patient's serum. It's collected 30 minutes prior to the next dose. The peak level is the highest concentration of drug in the patient's serum immediately before the dose is administered. Your book goes into this in great detail, and it actually covers the trough level is the lowest concentration in the patient's blood. We're going to collect this immediately prior to the next dose. It says not more than 15 minutes to administration of the drug. They give a 15 to 30 minute window. The peak level is the highest concentration, and your book doesn't actually give a time frame, but we want to do it immediately before the dose is administered. So this is when it would be at the highest in the system. Please review box 15/2 and also the clinical alert on time collection, because it's really important we collect these on time. So this is where we have collaborative efforts with nursing, pharmacy to make sure we're getting the most accurate test results for this particular test. TDMs, some examples of these would be our vancomycin drugs and our erythromycin drugs that are done via IV, because we need to watch to make sure the dosing is correct. Okay, the next part of this is we're going to look at our IV collections. Please also review in your textbook trace metal and genetic molecular tests. Those are just good things to review. IV line collection, not usually advisable to collect a blood specimen from the same arm as an IV as fluids dilute the specimen. If the arm with an IV is used, ask the nurse to shut off the IV for 1 to 2 minutes or the time required by the healthcare institutional procedure. After the venipuncture, ask the nurse to restart the IV. So when we draw, we're going to ask the nurse to shut the IV down for 2 minutes, and we draw below the IV, generally distally in the hand. We'll never draw above an IV unless the IV is no longer active and it's been more than 24 hours. Ideally, if the patient has an IV, we're going to try to use the other arm if it's advisable. So your book goes into the clinical alert, which is really important to reference. Also, too, I'm going to do a brief overview of the CVC collection and cannulas and fistulas, but it's really important for IVs that we don't draw above an IV site. This is what a PICC line looks like. Sometimes they come as a single lumen or double lumen, and sometimes they can draw blood from these. This would be a CVC line, central vascular catheter line, sometimes found in the neck. The collection procedure, a PICC is usually only used for blood collection when it's first inserted. It is a surgical procedure to insert, delivers long-term medication, IV, antibiotics, chemotherapy, and blood products. CVC collection, they swab the cap and the hub with an antimicrobial swab for 30 seconds and allows it to dry. They're going to use a 10 ml saline-filled needleless syringe into the cap and uncap the catheter. And then they're going to go ahead and flush the line. They aspirate slowly. They'll take another syringe and aspirate 5 ml of blood from the catheter for discard. Then they're going to do another syringe to collect their actual blood sample. and then they will flush the line again after they're done and swab the cap or replace it. So supplies needed is listed here. They check the patient's chart too to make sure there's an order to collect from a CVC line, and then in your book on procedure 15/7 goes over this in detail. We do not collect from this, but being aware of the procedure is really important because sometimes we get some of our blood samples from lines nurses collect. And please be aware that we don't want to draw near these lines. It is a surgical procedure to insert them. So just being aware of what they look like. Cannulas and fistulas. A cannula is this image here. It's a tubular instrument that is used in patients with kidney disease to gain access to venous blood for dialysis or blood collection. Fistula is an artificial shunt in which the vein and artery have been fused through surgery. We want to avoid collecting blood from these arms. They're generally used for dialysis. The other thing too, we won't want to apply a blood pressure cuff or tourniquet because it could actually impact those lines. And just being familiar with what they look like. Patients are very protective of these lines, so I don't think there will be an issue to where you won't notice it. Donor and therapeutic collection. Donor collection is blood should be collected by using an aseptic technique, a sterile closed system, and a single venipuncture. So your book goes into detail about the interview, date and time of donation. Last time, we do need written consent form signed by the donor, and I will have you just review this on your own. It also can be found in your textbook on page 500. They're going to do a physical exam, weight, temperature, pulse, blood pressure, and hemoglobin and hematocrit. Although the others are really important, we need to know the weight of the patient. If they're under 100 pounds, they may not be able to donate. If you have a fever or you have low blood pressure, you may not be able to donate. And ideally for your hemoglobin, they want your hemoglobin to be 12.5 or higher. Just because this is commonly used to collect blood from determination, also to make sure that there's an adequate supply for the patient and not causing them to pass out during the procedure. Please review on page 500 and 501 the rationale as to what lesions they're looking for, general appearance, and medical history. An autologous donation is a patient donates his or her own blood before the anticipated surgery. It's the safest blood a recipient can receive is his or her own blood. It eliminates the formation of antibodies in the transfused patient. So this would be ideal if you plan on have a predetermined surgery and you want to donate your own blood. Then there's therapeutic donation. This is initial removal of blood for therapeutic reasons for treatment of myeloproliferative diseases such as polycythemia, which is too many red blood cells, and hereditary hemochromatosis and other conditions in which there's an excessive production of blood cells. They'll actually take a pint of blood off of the patient. They can't use it for donation, but it is used to help decrease the production. So polycythemia, the overproduction versus normal. Okay, the other great thing to use in chapter 15 is the study questions at the end. Also to the actions and practice or case studies, just to review some concepts. This PowerPoint again was going over the really specific things in the chapter that I wanted to touch base on. Again, a lot of it is covering like the ABGs and blood culture collection. So really review those as you're going through your reading and your homework. The other thing to be aware of is we will actually perform a procedure in class twice on how to collect blood cultures. So this is going to be additional timing that will help you understand the procedure even further. That concludes chapter 15, chapter 15's lecture. Again, please view the discussion posted because it relates to this chapter as well as the homework.